Silverman. I'm a general surgeon. I'm also a specialist weight loss surgeon. I've been performing weight loss operations for the last 5 years. The idea behind this video is for me to explain about obesity being a chronic disease, and also what is involved with going forward with a weight loss operation. So you've been referred here likely from your GP or a specialist for help with management of your weight. GPs often need a hand in managing chronic health disease that are often associated with being overweight. These would include diabetes, high blood pressure, high cholesterol, and also issues such as reflux or difficulties with the abdominal wall. There also are a lot of cancers that are associated with being overweight, such as breast cancer or colon cancer. So I've just mentioned a few of the health concerns that we have from being overweight. Now, when does one need a weight loss operation? Well, the first thing we consider is what is your BMI. So BMI is a measurement taken from having your weight in kilograms divided by your height in meters squared. This can be worked out by myself, your GP, or yourself at home if you're interested. And what we would consider being the usual recommendation for a weight loss operation would be having a BMI over 35 with some weight-related health condition, or a BMI over 40. A BMI over 40 is considered to be morbid obesity. So the word morbid means that your weight is going to make you live less long and less well. So traditionally people that have been morbidly obese have been sent to dietitians and psychologists to help with management of their weight, and that is a very reasonable thing to do. The issue is for patients once they are morbidly obese, the success rate for them to not just lose weight but also to maintain weight loss in the long term with a diet and exercise program alone is somewhere under 2%. And we've often met these people, we can see them, often they become obsessive about what they eat. They become obsessive with exercise, which is great. They're generally young people with good joints that can run daily or swim daily, and have now involved health or wellness into part of their everyday life. So this 2% really represents the minority of patients. And in some ways, by prescribing a diet and exercise regime for those that are morbidly obese is almost setting someone up for failure. So saying the chance of you being able to maintain your weight loss with this is somewhere under 2%. It's a very hard pill to take. We've got some good information in regard that from something called the Swedish Obese Subjects Study. So this has been a study that's been run in Sweden for over 20 years that compared 2,000 patients that were morbidly obese that had a diet and exercise program versus around 2,000 patients that went on to have a weight loss operation. I'm just going to draw you on a graph to show you what happens with these patients over 20 years. So here we go. So this is time, and this is weight. So for those that are morbidly obese that just tried diet and exercise over 20 years, this is what happened to that cohort with that weight, i.e. it didn't change. Now, they looked at various weight loss operations that were available at that time, such as the bypass, which I'll discuss further, also the lap band, which I'll discuss further, and also a historical weight loss operation called the vertical banded gastroplasty, or the old gastric stapling. But if I just look at the weight loss curve for the gastric bypass, it goes something like this. Okay. And remember, this is over 20 years. So what you can see, and this graph I'll explain some more, because it goes in some ways to explaining that obesity is a chronic health disease. So that the genes that you are born with and the genes that become modified with time really set you up to remaining morbidly obese. These genes affect things like metabolism, appetite, and also things that we're not aware of, such as subconscious movement, to maintain you at that current weight. And you often hear the story of patients, they lose weight, which is great, but often they find that their weight regains back up to that set point level. And that goes into some way to explain the set point theory that people have with weight, i.e. your genes as they are, what they do is they maintain your current weight. Now, if we fool the genes and the body and metabolism with a weight loss operation, what we can see is quite dramatic weight loss, and most of that weight loss will happen in the first 1 to 2 years. And then the weight loss curve plateaus, and then there's this essence of weight regain. But over the 20 years, you can still see that there is a marked difference between those that just had diet and exercise alone versus those that went on to have a weight loss operation. The other important thing that was found in this Swedish obesity study is that those that had the weight loss operation actually had less chance of dying than those that just went for the diet and exercise program alone. And this is a very important concept. So if we look at the National Health and Medical Research Council recommendations on a weight loss operation, and also international recommendations of who should have weight loss surgery, they do mention BMI 40 or BMI 35 plus with some weight-related health conditions. And I've mentioned a few: diabetes, blood pressure, high cholesterol. We know at those levels that if we do a weight loss operation, not only will we make the patients live better, i.e. have less issues with carrying the weight, will actually help them to live longer. So that's the discussion we have. These operations and the recommendations for weight loss surgery are generally between the ages of 18 to 65 years. Save for adolescents or for the young that are morbidly obese, really they should be managed within an adolescent obesity clinic. Unfortunately, I'm not aware of any of such clinic in southeast Queensland, but for me, if I have a patient under 18 years of age, I'll send them to our dietitian and psychologist. I'll speak to them about various weight loss operations, but suggest that they become informed, and maybe we can consider that once they turn 18 years of age. That's obviously with the consent of their parents or guardians. When I talk to patients, say at the other end of that age range, so 65 years. Now, if you imagine if you're 65 and you've been overweight all your life, that weight or obesity has had some effect on the end organ. So it might have had an effect on the pancreas, it might have had effect on blood vessels, and that effect might not be reversible at that stage. So for older patients, say 65 and older, you might not necessarily be able to guarantee or help them to live longer with a weight loss operation, but certainly there may be quality of life benefits from having less weight at that time. So they're the discussions we have. Weight's interesting as well, really in the 70s, and as we get older in life, weight can actually be protective. It pads the bones, it makes the bones stronger, so can prevent things like osteoporosis and osteoporotic falls. When I make an assessment for someone when they come in, I'll have a look at the GP referral, I'll go through the medications that you're on, look at any chronic health diseases that you have, see what operations you've had previously. I'll also assess your smoking status. Now, this is an important one. Smoking really is a greater risk to your health and longevity than weight or being overweight is. Smokers also have an increased risk of having complications after surgery. So for this reason, I don't offer weight loss surgery for people that do smoke. I suggest they see the GP to discuss some methods of quitting smoking. And if they haven't read it already, I'd recommend Alan Carr's Easy Way on how to give up smoking. But really I'd need a patient or yourself to look me in the eye and say, I'm a non-smoker and I haven't had a cigarette for 3 months, and then we can consider a weight loss operation. For those that drink alcohol, moderate intake is fine. If patients have issues with alcoholism, really that really needs to be addressed pre-surgery, not just for the mental side of it, but if you have empty calories in the way of alcohol, no matter what operation you have, it'll be difficult to lose and maintain weight with it. What we look at with weight loss surgery is also managing your expectations. So I can give you the results of the various weight loss operations that I offer. So for the permanent weight loss operations, it's a sleeve gastrectomy. That's the most common operation I do. Also the gastric band and the gastric bypass. For those that aren't obese, say BMI 27 to 32, that are looking for a temporary weight loss measure, I would suggest perhaps a very low calorie diet or the Obese intragastric balloon. Now, when we look at how much weight people lose from these procedures, say, for example, the sleeve or the bypass, my results are for a weight loss of 70% of excess weight in the first 12 months after surgery. So what does excess weight mean? Well, say for someone that's morbidly obese, female, my height, if they were 140 kilograms, the ideal weight might be 70 kilograms, and that ideal weight is just taken from insurance tables, but their excess weight might be 70 kilograms. So the expectation would be to lose around 70% of that excess weight, i.e. around 49 kilograms at that 12-month mark. For the sleeve gastrectomy, and these are my results, 12 months weight loss results of 70% excess weight, and that amount will depend on your starting weight. What happens to the sleeve at 5 years, I don't know for me, but I've seen results in the literature. There's very scant literature of the sleeve at 10 years, but I'm assuming it's going to follow the same path as the gastric bypass, i.e. that there will be a tendency for weight regain in the long term. So what does this mean, this weight regain? Well, if I can redraw you that graph from the Swedish obesity study. So diet and exercise alone. And this will be your weight loss operation and then weight regain. So that's 12 months. That might be 20 years. So this goes back to that set point theory of obesity. So people wonder why they've regained weight after an obesity operation. And it's likely that the body just wants to go back to its normal metabolism, its normal appetite, that it has the genes that set it there. So it goes back to being to the set point theory. Now, for what we try to do with our multidisciplinary program, I've called it the PEAK program, which goes to show that there's more to weight loss than the technical aspects of the operation. So for each of the various permanent weight loss operations, the sleeve gastrectomy, the gastric band, the gastric bypass, every patient needs to maximise the results that they gain from that operation. So we can get your curve down to, I've had patients get to 100% excess weight loss, and they're the ones that have really worked on the whole wellness of it all. So they eat good foods, they exercise in the right way, they're mindful of what they're eating, and they're able to maximise the results of the weight loss. So for the first 12 months of an operation, it tends to be the weight loss just happens. My concern is what happens to you 3 years, 5 years, 10 years and 20 years down the track. So what we really want to do at this point is to make sure that you've got some good exercise behaviours, that you're eating the right foods, that you're mindful of what you're eating, so we can help to avoid this weight regain in the long term. I see patients first in clinic. I organise to see if they're appropriate for a weight loss operation. I'll send you off for some blood tests if they haven't already been done by a general practitioner, as well as things like cholesterol, glucose, thyroid hormones, which I'm assuming may have been done before. I'll also look for nutrients, vitamin D, the vitamin Bs, thiamine, and these nutrients testing is also repeated at the 12-month mark. I'll send you to see the Peak team's dietitian and psychologist, and these professionals are actually experts in this field of bariatric surgery. That's what they do. They know about the operations. We meet as a team. We discuss how you get the most benefit from your surgery, and also with the aim of being able to maintain your weight loss lifelong. I also often get asked, can I see my own psychologist? And look, that's fine, but the psychologists I have great expertise in weight and also the management of weight after obesity surgical services. Can I see my own dietitian? Well, you really need to see someone that specialises and is aware of my requirements. So before surgery, most patients will go on something called a very low calorie diet. This is sort of what you might see from the chemist in the version of OptiFast, OptiSlim, Tony Ferguson. But the idea is low carbohydrates, low calories for 2 weeks or a defined time pre-surgery to shrink the liver. It's a liver shrinking diet, so this helps make the surgery easier for me and safer for you. Sometimes when I operate on patients, say over 200 kilograms, or patients BMI 50, that's super morbidly obese, or BMI 60, BMI 50 is super morbidly obese, BMI 60 is a super morbidly obese group. We might ask you to be on a very low calorie diet for a little longer pre-surgery, just to make the surgery easier for me and safer for you. So the dietitian will help you with a very low calorie diet. They also help you post-surgery with the diet that's required. For all the operations, the band, the sleeve, the bypass, there is a requirement for you to be on a fluid-only diet for 2 weeks after the procedure. The next 2 weeks you're on a pureed diet, and you commence a normal texture diet by around the 4-week post-procedure. What is important as well, specifically with a dietitian and their advice, is that you lose the good weight. So we want you to be losing fat, we don't want you to be losing muscle. And if we did nothing to redress your muscle mass, you'd be losing 3 parts fat to 1 part muscle every time you lose a kilo. And obviously the most important thing for you is to be maintaining that muscle mass. So we might need to add extra proteins, either pre-surgery on your very low calorie diet, but also post-surgery to avoid the loss of muscle mass. In the longer term, specifically down the latter end of the path, after you've lost some weight, there's less weight on your joints, you're more mobile, there'll be an encouragement for exercise. This exercise takes place not just going to the gym or running or swimming, but it's in 3 ways. One is the exercise we do every day in our incidental activities, so workplace habits need to be looked at. I'm sitting down now, but really I should have a standing workstation. I move around as much as I can in the office because that's important. I try to do as much chores at home, like wash the car and mow the lawn and rake the leaves, and they're all part of what we call incidental activities, or the acronym is NEAT, non-exercise activity thermogenesis. So we all need to keep on moving. We also, in terms of exercise, need to do some cardiovascular training and also importantly resistance training. So resistance training, specifically using our big muscles, helps to grow muscle mass. So that with additional proteins will make sure that we don't lose muscle bulk. And also in the long term, if we have an increased muscle mass, it means our actual basal metabolic rate increases. So when our operation starts to relax a little bit, our metabolism rate will go up, so we can afford to eat a little bit more. So the dietitians are very instructive of this. They actually have something called an impedance monitor. So it's a special scale that you stand on and hold on to the bars that can measure muscle and fat ratios. So we can keep an eye on not just your weight loss, but making sure that the weight that you've lost is good weight. We want you to lose fat and not muscle. In fact, by the end of the program, our aim is really to have you to see a gain in the muscle mass. So that's where the dietitian is important. I'll refer you to both the psychologist and dietitian pre-surgery, helps you with a very low calorie diet. I'll explain about the operation. It also gives you time to have a think about it, and then you'll come back to see me for a final pre-surgery visit. Now at that visit, I'll go through all the blood tests that you've had. I'll make sure you've got a good understanding about the operation, and really it's an opportunity for you to ask me any further questions that you have, because my aim is that you maximise the weight loss results from this operation, you get through the operation safely, but beyond that, you maintain your weight loss over the long term. Pre-surgery, you'll go on your pre-surgery diet. At surgery, you'll have your operation. At this point, I'm doing my operations at John Flynn Hospital. It's a very experienced hospital when it comes to managing patients of size. The sleeve, the band and the bypass are all done as keyhole operations. You'll have 5 small incisions. Patients that have had the gastric band stay in 1 night. Patients that have had the sleeve or the bypass will stay in 3 nights. Post-surgery, you'll be on a fluid-only diet for 2 weeks. This is going back to the shakes, the protein shakes that you were having pre-surgery. So that's for the first 2 weeks. The next 2 weeks you're on a puree type diet, and by the 4-week mark you're back on a full textured diet. And that's when you come back to see me for your first review. If you have any problems at all in that first 4 weeks post-surgery, obviously I want to know about it sooner. The dietitian will see you at 2 weeks after the operation. They tend to let me know if you're running into any troubles, but I see patients back at the 4-week mark for their first review. In the first 12 months post-surgery, I see you at the 1-month mark, 3-month mark, 6-month mark, and the 12-month mark. I keep a track of your weight. I note symptoms if you're having any issues swallowing or you're having any issues with reflux. I help you manage those. At the 3 to 6 month mark, hopefully you've lost around 20 kilograms of weight at this point, and it's a much better time to talk about exercise. I can give some pointers, but we have an exercise physiologist on the team as well. She can help you with an exercise prescription. And then I see you at the 12-month mark. You'll have a repeat blood test to make sure that you have no deficiencies in your micronutrients. All patients that have had these operations should be on multivitamins lifelong. And it's not because any of them are malabsorptive operations, it's just because you can only eat a smaller amount. You don't want to get any deficiencies of your micronutrients. So you'll be on multivitamins lifelong. At the 12-month mark, it's generally a very happy occasion. Patients have lost the majority of the weight they're going to lose. It's at this point that I'm happy to assess the abdominal wall. A lot of patients say that have had hernias when they're morbidly obese. They're actually too overweight for me to be able to fix them safely. At the 12-month mark post-surgery with weight loss, I'll actually also, as well as assessing hernias of the abdominal wall, assess if you have any excess skin that you'd like dealt with. I do a functional abdominoplasty or apronectomy to deal with the excess skin that you have at the lower part of the abdomen. If you have excess skin, say breasts, between the arms or in thighs, I'll be happy to refer you to a plastic surgeon or a breast surgeon to deal with these. Now, what happens over the longer term? Well, really that's where the challenge lies. And the team, myself, the dietitian psychologist, do remain available if you have issues with weight regain. But I think for us to say, when you're at this point, morbidly obese, diet and exercise alone, to help you lose and maintain weight is almost like asking someone to do a mission impossible. But really at this point, when you've lost the weight, you really need to change your life around, and at that point maintaining the weight can be made mission possible.